The human diaphragm separates the chest cavity from the abdomen, but isn't a solid wall. It contains a precise opening called the esophageal hiatus. This aperture allows the esophagus to pass through the diaphragm to meet the stomach, acting as a structural collar that maintains a functional pressure barrier between the two cavities. When the architecture at this junction weakens, that collar loosens and the pressure barrier is compromised. This localized structural failure is defined as a hiatus hernia. Clinical observation shows that this breakdown is not a random event. It is driven by specific physiological stressors documented in pathology. These clinical notes map 4 primary etiological drivers that ultimately dictate 3 distinct morphological patterns of herniation. Identifying these hernias requires mapping these specific causative stressors directly to the anatomical deformations they produce. The first etiological driver is the progressive degeneration of muscle tissue at the hiatus that occurs with aging. The second stressor is a sustained increase in intra-abdominal pressure, occurring in conditions that increase internal volume, most commonly pregnancy or abdominal tumors. This systemic pressure pushes upward, concentrating force specifically against the diaphragm's weakest structural point. The third cause involves recurrent esophageal regurgitation and Wasmuir spasm. Chronic regurgitation leads to local inflammation, resulting in structural shortening and scarring known as fibrosis. The fourth factor is obesity, which introduces excess fatty tissue to the region. This accumulation directly decreases the muscular elasticity of the diaphragm itself. Whether through upward pressure, chemical fibrosis, or a loss of elasticity, the hiatus becomes structurally compromised and mechanically primed to fail. Once the hiatal structure is compromised, the stomach breaches the diaphragm in statistically predictable patterns, the foremost being the sliding hernia. This specific mechanical failure accounts for 85% of all documented cases. In a sliding hernia, the gastroesophageal junction and the stomach tissue displace symmetrically upward through the widened hiatus. Because the displacement is vertical and even on both sides of the esophagus, it creates a very specific shape. The displaced gastric tissue forms a symmetrical bell shape above the diaphragm line. This is classified in clinical terminology as a supradiaphragmatic bell. In the vast majority of hiatal failures, the underlying stressors result in this direct, symmetrical upward slide of the gastric system. The second, less common pattern of failure operates on a different mechanical principle. The rolling hernia is seen in only 10% of cases. Unlike the sliding type, the gastroesophageal junction in a rolling hernia remains anchored below the diaphragm. Instead of the entire junction moving, the cardiac end of the stomach pushes up alongside the intact esophagus. This parallel movement is described as occurring paraesophageally. This asymmetrical mechanism creates a self-contained pouch of stomach tissue sitting fully above the diaphragm, an intrathoracic sac. Clinical pathologists classify the rolling variant as a true hernia because a portion of the organ is protruding into a separate anatomical compartment. While a sliding mechanism moves the entire junction upward, a rolling mechanism traps a parallel sac of tissue in the chest cavity. There is a final category for cases that do not fit into the standard sliding or rolling classifications. This is the mixed or transitional hernia. It represents the final 5% of diagnosed hiatal failures. This represents a compound anatomical failure, where the patient experiences both the upward sliding of the junction and the parallel rolling of a sac simultaneously. Severe degradation of the hiatal ring can lead to the simultaneous expression of multiple hernia mechanisms, increasing clinical severity. Hiatus hernias are predictable, mechanically driven structural failures. The failure is instigated by 4 primary physical drivers: systemic pressure, age-related degeneration, fibrosis, or a loss of muscular elasticity. These stressors resolve into highly predictable statistical probabilities. There is an 85% probability of a symmetrical sliding supradiaphragmatic bell, contrasted with a 10% probability of an asymmetrical rolling intrathoracic sac. Identifying these specific morphological patterns is necessary to anticipate complications and plan effective treatment. The distinct patterns of hiatal failure are not separate clinical conditions, but the predictable mechanical results of a single structural ring yielding to localized physiological stress.